When the cancer is diagnosed early, by and large, surgery is the treatment of choice. But even when surgery is done, we are able to study the pathology specimen and estimate or prognosticate what is the risk of cancer recurrence. If we believe that the risk of cancer recurrence is high, we will add on either chemotherapy, radiotherapy, or both in order to lower the chance of the cancer recurring. So that is the situation where surgery is used up front and then you add on either chemotherapy or radiation. There are some cancers which are very, very sensitive to chemotherapy, where there's no need for you to either add on radiation or surgically intervene. Let me illustrate. This is a young boy that came to see us with a very advanced testicular cancer. You can see the huge testicular tumor. You can see the tumor has literally broken through in the abdomen. And I'm going to show you a whole sequence of pictures. All right, you can appreciate it is now the hole is closing up and the tumor is getting smaller. And as it continues to die, you can see the wounds. Gradually, you can see the scrotum getting smaller, the tumor dying off. All right, the wound gradually closes by itself. All right, you can see the wound still. Now you can just see almost just a scar. No surgery was done on this patient. All right, you can see the wound has healed up nicely. Okay, this is the same boy. And he's grown up. All right, this is a situation where the tumor is extremely sensitive to chemotherapy. Most testicular cancers are treated with chemotherapy alone. As in this case, the disease was so advanced, it had literally broken through the abdomen. And yet, with the chemotherapy, this boy remains alive and well. Good cancer treatment requires a partnership bringing together specialists from various areas. It starts from one, the clinician making a diagnosis and ordering the appropriate investigations. It requires a team of radiologists who are specialized, who can interpret and stage the cancer accurately to tell us how extensive the cancer is. It requires pathologists who are able to make an accurate histologic diagnosis of what type of cancer it is. All right? Then we bring together the three main arms, the surgeon, the radiotherapist, and the medical oncologist. And we must plan what is best for the patient. Is surgery required? Would chemotherapy do the job? Should we proceed with radiation? And then we will give a treatment plan to the patient, explaining why we have decided to treat it in the following manner. And giving them an understanding of what is the goal. Is the goal of management to cure or merely to control the disease, preserve the quality of life, and to prolong life? And most importantly is to look after the psychosocial well-being of the patient, for him to understand and to cope with the disease. Under the banner of Parkway Cancer Center, we have also brought in tomotherapy. Tomotherapy is another form of radiation treatment. The big difference between conventional radiotherapy and tomotherapy is in tomotherapy, we are able to target the tumor and the tumor alone, sparing the neighboring structures. Advances are going on in many, many fronts. The PET-CT scanner, as I told you about, tomotherapy, drugs. Drug development is very exciting. Now we have what we call targeted cancer treatment. In other words, because we understand the molecular basis of the cancer, we know what are the genes that are actually promoting the cancer. We actually have the ability now in certain cancers to just switch off the gene. Now, because of our understanding of cancer, the availability of new drugs, we are able to help these patients, no, they are not cured, help these patients to have the disease controlled, under control, enjoying good quality life. That's what medicine is all about.